Mitchell. Today I wanted to look at increasing engagement amongst Black and ethnic minority communities. I currently work as a stop smoking specialist within CLCH. We basically got a target from the Department of Health that focuses on getting about 1,200 people to give up smoking. But personally I feel that we don't focus on health inequality. So for example, particular groups, for example within the Black ethnic community, we basically focus on just getting these quitters, but I think we're not looking at how to actually combat health inequalities within our area. So today in my presentation I wanted to look at ways that we can increase working with BME communities. My project's quite large. I was actually going to carry it out, but we're actually moving to a private organisation. So my manager said, rather than start partnership working with different organisations, if we can't commit to actually delivering this programme, just put it on hold. So this is what I basically thought we should do, looking at current research and what other stop smoking services within the UK are doing. I just wanted to, the end of the presentation is to provide some background information as to why the area was chosen for the improvement project, briefly look at the health outcomes of residents who live in Kensington and Chelsea, discuss the management of improvement projects, and also discuss challenges of improvement projects and what working for the NHS means to me. Background information. Okay, so smoking remains the main cause of premature mortality and premature death in England. The reduction of tobacco consumption among minority groups would reduce health inequalities more than any other measure. The prevalence of smoking is declining amongst the general population. However, amongst smokers within ethnic minorities, this is not the case. The Health Survey for England 2004 showed that ethnic minority groups are more likely to report ill health than the general population. The National Office for Statistics said that ethnic minorities had the highest prevalence of cigarette smoke at 27% compared to the general population. However, when we're looking at our database as a service, the proportion of BME clients is very small compared to the general population. So that shows me that we need to adapt our way of working when working with ethnic minorities. Okay, so this is health outcomes for BME residents in Kensington and Chelsea. So if you're basically living in Kensington and Chelsea, you're more likely to live longer than living in any other borough. However, if you're from a Black community, you're more likely to die earlier than any other race due to health inequalities that you currently experience. And as you can see, Kensington and Chelsea is higher than the London average. Plan to improve engagement among ethnic minorities. Okay, so increase the numbers of ethnic minorities accessing the service. Use public health promotions to educate ethnic minorities about smoking and smokeless tobacco. Currently there's no guidance from NICE how to support clients to reduce the consumption of smokeless tobacco. However, a lot of people from BME communities have oral diseases, cancer from chewing tobacco, but there's no documentation as to how we should support these clients to actually stop chewing tobacco, which is causing cancer. Improve partnership working amongst ethnic minority organisations, and with that, what I mean is community organisations know their client group, so if we can engage better with community organisations, we can hopefully get people to take more autonomy over their healthcare. It also reduces the barriers in terms of language barriers, because community organisations, they know their client groups. Engage with community organisations to become champions of health. A lot of the research say that, particularly within the Pakistani and Bangladeshi community, they see smoking as part of their culture. So it's quite hard as a health professional if you're trying to challenge somebody's culture, because that's basically part of their identity. So if we work, for example, like with mosque leaders, they're obviously an advocate for their community and health, so we need to do better, we need to engage better with community leaders. We also need to improve language barriers. Currently as a service, we just had a generic leaflet. As you can appreciate, in London there's over 300 languages spoken. And also, I just wanted to make a point, just because we adapt a leaflet in a certain language doesn't mean that a person has the literacy levels to understand that leaflet. So we need to think of new innovative ways of communicating health messages to our population. By working with community organisations, I think this would be a way of eliminating those language barriers. Continue. Increase referral pathways amongst VME and community organisations. This is particularly challenging because obviously at the moment a lot of community organisations have difficulties with funding. So when you go with them with your health agenda and they've got their own agenda, it's quite difficult. Before we used to be, we were able to commission services, but now we provide the services. We can't give funds to community organisations to refer clients to us. However, we can actually physically go into community settings and offer these services for the patients. Look at new innovative ways to engage VME residents in improving healthcare. For example, I spoke to some community organisations and they thought it would be a good idea if we did like healthcare events targeted at particular groups, for example, the VME community. We also need to provide targeted intervention. I've personally worked with GP practices and actually access their system of clients who smoke within surgeries and actually sent them a letter offering them our services. This has been a crucial way of actually engaging clients into our service. Previously as a service, my managers basically decided to employ other organisations to get smokers to access our service. But we've got over 40 GPs in Kensington and Chelsea, and we know who smokes. It doesn't make sense paying external organisations when we've got the information of who smokes and we're not doing anything with it. We also need to do more collaborative working to address the wider determinants of health. If you're, for example, from an ethnic minority, it's more likely that you're going to basically be poor. So therefore, we need to work closer with job centres, because if somebody doesn't have an income and they're going into job centres, we need to be doing health checks with people within those settings to address the wider determinants of health. We also need to be working with housing providers. 20% of, even though Kensington and Chelsea is an affluent borough, 20% of people live within social housing, and those people who live within social housing are experiencing health inequality, so we need to work with external organisations, for example, housing providers, to reduce these health inequalities. And that's it. Do you have any questions?
I have a comment.
Gabriella.
The fact that your service is moving as a result of commissioning intention, and you were saying this project has been passed. But my understanding is it's still being commissioned by Public Health.
Yeah, it is.
And in one sense, some of your earlier analysis, the case for doing the outreach that you wanted to do, could still be shared with the Public Health commissioners, and saying, we have this thought, we have this commission, we think this need is there that we haven't been able to meet. Even though you might be with a different provider, pushing the case through back to the Public Health.
Yeah, and I do think this work is actually going to carry on, because we've met with our new providers, and the way that Public Health is structured, our target is we need to get X number of critters, but also we need to be doing prevention work with a lot of these communities. So I do hope this is going to follow forward, but I also wanted to, for example, like adapt a leaflet for ethnic minorities, because I'm doing my Masters in Public Health currently, and universal intervention is not targeting the needs of our community, so we need to adapt our services to meet the needs. We need to be becoming a proactive service, because the NHS currently spends £50 million a week treating smoking-related illnesses, and at the end of the day, people are dying earlier, so yeah, so I do agree.
Well, you're obviously a person on a mission with that. Good.